One of the most important things about being a medical coder is understanding all of the different medical coding guidelines, and that's why I'm continuing this series today on the ICD-10-CM guidelines. Today we'll be going over cardiovascular and respiratory. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If this is your first video here, you may want to go back. I started a playlist because I am going through the complete ICD-10-CM coding guidelines, so from chapter 1 through chapter 22. Chapter 9 is diseases of the circulatory system, and we'll also be going over chapter 10, diseases of the respiratory system. So let's get into those guidelines. All right, so back into our chapter-specific guidelines. So we finished off with chapter 7 last time, and chapter 8 actually does not have chapter-specific guidelines. You can see right here, reserved for future guideline expansion. So we're going to get right into chapter 9, diseases of the circulatory system, and it starts with hypertension. The key thing you need to know with hypertension is that there is an assumed cause and effect relationship with hypertension and chronic kidney disease and hypertension and heart disease. So let's get into that. So those two conditions are linked by the term with in the alphabetic index. So there's a presumed causal relationship between hypertension and heart involvement, hypertension and kidney involvement. These conditions should be coded as related even in the absence of provider documentation specifically linking them. For hypertension and conditions not specifically linked by relational terms such as with, associated with, or due to in the classification, the provider documentation must link those conditions, but hypertension and heart disease, hypertension and chronic kidney disease automatically assumed to be linked. So for example, if the provider documents diagnosis 1, hypertension, diagnosis 2, heart disease, anything that's classified from the I-50 category or the ones listed here, I-51.4, I-51.7, I-51.8, 89, I-51.9, they are assigned to category I-11 because they're assumed to be hypertensive heart disease, even if the provider puts number 1, hypertension, number 2, heart disease. First, you would list the I-11 code, and then you would use that I-50 or I-51 code to identify that type of heart failure. The same heart conditions, and it lists them all here, with hypertension are coded separately if the provider has documented they are unrelated to the hypertension, sequenced according to the circumstances of the admission or encounter. So same kind of deal with hypertension and chronic kidney disease. If the provider documents number 1, hypertension, number 2, chronic kidney disease, or end-stage renal disease, anything that's categorized to that N18 category, those are assumed to be related unless the provider specifically says they are not related. So you would assign that I-12 code first, and then one from a category N18 as a secondary code to identify the stage of the chronic kidney disease. If the patient has hypertensive chronic kidney disease and acute renal failure, then the acute renal failure should also be coded, and we're going to sequence according to the circumstances of the admission or encounter. Now, if the patient has all three of them, hypertension, heart disease, and chronic kidney disease, same cause-effect relationship, it is assumed to be hypertensive heart and chronic kidney disease, but we assign that to category I-13, which is hypertensive heart and chronic kidney disease. If heart failure is present, then we assign that additional code from category I-50 to identify the type of heart failure, and then the appropriate code from that N18 to identify the type of chronic kidney disease based off of the stage. So those come after that I-13 code. So let's take a look quick in our book so I can show you a little bit what that looks like. So here, if you open your books to your I sections in the I-10, I-11, I-12, you can see we have our I-10 code, which is just our essential primary hypertension. I-11 is our hypertensive heart disease. I-12 is our hypertensive chronic kidney disease. And then I-13 is our hypertensive heart and chronic kidney disease. And they give you instructions in the book, and I'll try to zoom in here. They do give you instructions in the book to show you what the additional codes are. So if you forget, oh yeah, am I supposed to assign a code for the stage of chronic kidney disease, or is that included? They do give you that. They tell you to identify the type of heart failure and identify the type of chronic kidney disease. So that instruction is right in there. So those are subsequent codes you can tell because the instructions are right in the book. The codes in category I-13, hypertensive heart and chronic kidney disease, are combination codes. So that includes the I-11 and includes the I-12 codes. You would not code those in addition to I-13. If a patient has hypertension, heart disease, and chronic kidney disease, then you code from I-13 and don't use those individual codes for hypertension, heart disease, and chronic kidney disease. For patients with both acute renal failure and chronic kidney disease, the acute renal failure should be coded, and then you sequence it according to the circumstances of the admission or the encounter. For hypertensive cerebrovascular disease, you would assign the appropriate code from categories I-60 through I-69, followed by the appropriate hypertension code. If you look at the codes for I-60, it also tells you to use any additional codes to identify the presence of alcohol abuse, exposure to environmental tobacco smoke, history of tobacco dependence, hypertension, occupational exposure to environmental tobacco smoke, tobacco dependence, or tobacco use. Hypertensive retinopathy is subcategory H35.0, which is background retinopathy and retinal vascular changes, and this should be used with a code from category I-10 through I-15, hypertensive disease, to include systemic hypertension. The sequencing is based off of the reason for the encounter. Secondary hypertension is due to an underlying condition, so that means we need to have two codes. One to identify the underlying etiology and one from category I-15 to identify the hypertension. Sequencing of the codes is determined by the reason for the admission or the encounter. Transient hypertension is assigned code R03.0, which is elevated blood pressure reading without the diagnosis of hypertension, unless the patient has established a diagnosis of hypertension. Hypertension transient, so we assign code R03.0 when the patient has an elevated blood pressure reading without a formal diagnosis of hypertension, unless of course the patient has an established diagnosis of hypertension. If it is a patient who is pregnant, we would assign code 013 for gestational pregnancy-induced hypertension without significant proteinuria, or 014, which is preeclampsia, for transient hypertension of pregnancy. Hypertension control, that diagnostic statement usually refers to an existing state of hypertension under control by therapy, so we would assign whatever the appropriate code is from categories I-10 through I-15 for our hypertensive diseases. Hypertension uncontrolled may refer to untreated hypertension or hypertension not responding to therapeutic regimen. In either case, same thing, we assign whatever the appropriate code is from I-10 through I-15 for hypertensive diseases. Hypertensive crisis is a little bit different. That's category I-16, hypertensive crisis, and that's for documented hypertensive urgency, hypertensive emergency, or unspecified hypertensive crisis. We code also any identified hypertensive disease, which is I-10 through I-15, and the sequencing is based off of the reason for the encounter. Pulmonary hypertension. For pulmonary hypertension, it's classified to category I-27, other pulmonary heart diseases. For secondary pulmonary hypertension, which is codes I-27.1 or I-27.2, and then the fifth digit, we would code also any associated conditions or adverse effects of drugs or toxins. The sequencing is based off of the reason for the encounter, except for those adverse effects of drugs, and see section 1C19.E, which we'll talk about later for those. Atherosclerotic coronary artery disease and angina. ICD-10-CM has a combination code for these. The subcategories for these codes are I-25.11, atherosclerotic heart disease of native coronary artery with angina pectoris, and I-25.7, which is atherosclerosis of coronary artery bypass grafts and coronary artery of transplanted heart with angina pectoris. When using one of these combination codes, it is not necessary to use an additional code for angina pectoris. It's already included in there. So a causal relationship can be assumed in a patient with both atherosclerosis and angina pectoris unless the provider indicates that the angina is due to something other than the atherosclerosis. If a patient with coronary artery disease is admitted due to an acute myocardial infarction, the AMI should be sequenced before the coronary artery disease. Intraoperative and post-procedural cerebrovascular accidents, the medical record documentation has to specifically have the cause and effect relationship between the medical intervention and that cerebrovascular accident in order to assign a code for intraoperative or post-procedural CVA. Proper code assignment depends on whether there was an infarction or hemorrhage and whether it occurred intraoperatively or post-operatively. If it was a cerebral hemorrhage, code assignment depends on the type of procedure that was performed. Sequela of cerebrovascular disease. So category I-69, sequela of cerebrovascular disease. That's used to indicate conditions classifiable to categories I-60 through I-67 as the causes of sequela, so neurological deficits themselves classified elsewhere. These late effects include neurologic deficits that persist after an initial onset of conditions classifiable to categories I-60 through I-67. The neurologic deficits caused by cerebrovascular disease may be present from the onset or may arise at the time after the onset of the condition classifiable to categories I-60 through I-67. Let's actually take a look at this in the book. When you head to your I-69 section in the ICD-10-CM manual, and I'll zoom this in, it will show you under I-69, it tells you that you can see the official guidelines here for sequela of cerebrovascular disease. And there's a note here, category I-69 is to be used to indicate the conditions in I-60 through I-67 as the cause of sequela. So here we go, we can kind of look at these. What do we got here in our I-69? Sequela of cerebrovascular disease, non-traumatic subarachnoid hemorrhage, speech and language deficits, monoplegia of upper limb, monoplegia of lower limb. Let's see, other sequela of non-traumatic. We have here speech and language deficits following non-traumatic intracerebral hemorrhage, monoplegia of upper limb following non-traumatic. So there's a lot of different specified types of sequela to pay attention to here. Codes from category I-69, sequela of cerebrovascular disease, that specify hemiplegia, hemiparesis, and monoplegia identify whether the dominant or non-dominant side is affected. Should the affected side be dominant but not specified as dominant or non-dominant, and the classification system does not indicate a default, we would code it as follows. For ambidextrous patients, the default should be dominant. If the left side is affected, the default is non-dominant, and if the right side is affected, the default is dominant. Codes from category I-69 with codes from I-60 through I-67. Codes from category I-69 may be assigned on a healthcare record with codes from I-60 through I-67 if the patient has a current cerebrovascular disease and deficits from an old cerebrovascular disease. Codes from category I-69 and personal history of TIA and cerebral infarction. Codes from category I-69 should not be assigned if a patient does not have neurological deficits. Acute myocardial infarction, type 1 ST elevation myocardial infarction, or a STEMI, and non-ST elevation myocardial infarction, which is an NSTEMI. The ICD-10-CM codes for type 1 acute myocardial infarction identify the sites such as anterior lateral wall or true posterior wall. Subcategories I21.0 through I21.2 and codes I21.3 are used for type 1 ST elevation myocardial infarctions. Code I21.4 is for the non-STEMI myocardial infarctions and is used for type 1 and transmural MIs. If a type 1 NSTEMI evolves to a STEMI, assign the STEMI code. If a type 1 STEMI converts to an NSTEMI code due to thrombolytic therapy, it is still coded to a STEMI. For encounters occurring while the myocardial infarction is equal to or less than 4 weeks old, including transfers to another acute setting or post-acute setting, and the myocardial infarction meets the definition for other diagnoses, codes from category I21 may continue to be reported. Now, here's the important thing, this 4-week period, and this is something that if you're taking your exam, highlight it because you may see it on your exam. I'm not saying you will, but it's something that they like to ask, relationship to this time period for these myocardial infarctions. So for encounters after the 4-week, remember that, 4-week time frame, and the patient is still receiving care related to the myocardial infarction, the appropriate aftercare codes should be assigned rather than a code from category I21 from category I21. For old or healed myocardial infarctions not requiring further care, code I25.2 old myocardial infarction may be assigned. Acute myocardial infarction unspecified. Code I21.9 for acute myocardial infarction unspecified is the default for the unspecified acute myocardial infarction or unspecified type. If only type 1 STEMI or transmural MI without the site is documented, assign code I21.3 ST elevation myocardial infarction of unspecified site. For AMIs that are documented as non-transmural or subendocardial, but the site is not provided, it is still coded as subendocardial AMI. Subsequent acute myocardial infarctions, a code from category I22, subsequent ST elevation and non-ST elevation myocardial infarction is to be used when a patient who has suffered from a type 1 or unspecified AMI has a new AMI within that 4-week time frame of the initial AMI. A code from category I22 must be used in conjunction with a code from category I21. The sequencing of I22 and I21 depends on the circumstances of the encounter. Do not assign code I22 for subsequent myocardial infarctions other than type 1 or unspecified. For subsequent type 2 acute myocardial infarctions, assign only code I21.A1. For subsequent type 4 or type 5 AMIs, assign only code I21.A9. If a subsequent myocardial infarction of one type occurs within the 4 weeks of a myocardial infarction of a different type, assign the appropriate codes from category I21 to identify each type. Do not assign a code from I22. Codes from category I22 should only be assigned if both the initial and subsequent myocardial infarctions are type 1 or unspecified. Other types of myocardial infarctions. So the ICD-10-CM codes for different types of myocardial infarction. Type 1 myocardial infarctions are assigned to codes I21.0 to I21.4. Type 2 myocardial infarction or myocardial infarction due to demand ischemia or secondary ischemic imbalance is assigned to code I21.A1 myocardial infarction type 2 with the underlying cause code as the first code. Do not assign code I24.8 other forms of acute ischemic heart disease for the demand ischemia. If a type 2 acute myocardial infarction is described as NSTEMI or STEMI, assign only code I21.A1. Codes for I21.01 and I21.4 should only be assigned for type 1 acute myocardial infarctions. Acute myocardial infarctions type 3, 4A, 4B, 4C, and 5 are assigned to code I21.A9, which is other myocardial infarction type. The code also in code first notes should be followed related to complications and for coding of post-procedural myocardial infarctions during or following cardiac surgery. If you look in your book at I21.A1 and I21.A9, you can see that there's some code first notifications in here, as well as some here it says to code also the complication, if known, such as the acute stent occlusion, acute stent stenosis, etc. So pay very, very close attention to all the different notes that are in this particular area. So next let's get into chapter 10, which is diseases of the respiratory system, J00 through J99, and then it also includes U07.0, which I believe is our code for vaping disorder. So we're going to start with COPD and asthma, an acute exacerbation of chronic obstructive bronchitis and asthma. The codes and categories J44 and J45 distinguish between uncomplicated cases and those in acute exacerbation. An acute exacerbation is a worsening or decompensation of a chronic condition. An acute exacerbation is not equivalent to an infection superimposed on a chronic condition, though an exacerbation may be triggered by an infection. If you check out your J44, you can see it says other chronic obstructive pulmonary disease. It references the guidelines, and then it does include here the use additional codes to identify if there's tobacco exposure, etc. And then down here we have our code for Asthma, same thing. Use additional codes to identify if there's tobacco use, history of tobacco dependence, etc. And pay close attention to the includes and the excludes notes here on your asthma coding. Acute respiratory failure as the principal diagnosis. A code from subcategory J96.0, acute respiratory failure, or subcategory J96.2, acute and chronic respiratory failure, may be assigned as the principal diagnosis when it is the condition established after study to be chiefly responsible for occasioning the admission to the hospital, and the selection is supported by the alphabetic index and the tabular list. However, chapter-specific coding guidelines, such as the ones for OB, which we know always take precedence, poisoning, HIV, and newborn that provide sequencing direction take precedence. Acute respiratory failure as a secondary diagnosis. Respiratory failure may be listed as a secondary diagnosis if it occurs after admission or if it is present on admission but does not meet the definition of principal diagnosis. Sequencing of acute respiratory failure and another acute condition. So when a patient is admitted with respiratory failure and another acute condition, like an MI, like cerebrovascular accident, like aspiration pneumonia, the principal diagnosis will not be the same in every single situation. This applies whether the other acute condition is a respiratory or non-respiratory condition. Selection of the principal diagnosis will be dependent on the circumstances of the admission. If both the respiratory failure and the other acute condition are equally responsible for occasioning the admission, so why it caused the admission to the hospital, and there are no chapter-specific sequencing guidelines, the guideline regarding two or more diagnoses that equally meet the definition for principal diagnosis apply in those situations. If the documentation is not clear as to whether acute respiratory failure and another condition are equally responsible for the reason for the admission, just go ahead and query the provider for clarification. Influenza due to certain identified influenza viruses. Code only confirmed cases of influenza due to certain identified influenza viruses, so category J09, and due to other identified influenza virus, category J10. This is an exception to the hospital inpatient guideline section 2H, which is uncertain diagnosis. In this context, confirmation does not require the positive lab result. Again, it can just be provider documentation, provider statement that the patient has that condition. However, the coding should be assigned based off of the provider's diagnostic statement that the patient has avian influenza or other novel influenza A for category J09, or has another particular identified strain of influenza such as H1N1 or H3N2, but not identified as novel or variant for category J10. If the provider records suspected or possible or probable avian influenza or novel influenza or other identified influenza, then we can assign the appropriate influenza code from category J11. Influenza due to unidentified influenza virus should be assigned. A code from category J09, influenza due to certain identified influenza viruses, should not be assigned, nor should a code from category J10, influenza due to other identified influenza virus. Ventilator-associated pneumonia, so documentation of ventilator-associated pneumonia. As with all procedural and post-procedural complications, code assignment is based on the provider's documentation of the relationship between the condition and the procedure that led to that condition. So code J95.851, ventilator-associated pneumonia, should only be assigned when the provider has documented ventilator-associated pneumonia. An additional code to identify the organism should be assigned. Do not assign a code from categories J12 through J18 to identify the type of pneumonia. So do not assign those codes in addition to the ventilator-associated pneumonia. Code J95.851 should not be assigned for cases where the patient has pneumonia and is on a mechanical ventilator, and the provider has not specifically stated that the pneumonia is ventilator-associated pneumonia. If the documentation is unclear as to whether the patient has pneumonia that is a complication attributable to the ventilator, query the provider. Ventilator-associated pneumonia developing after admission. So a patient may be admitted with one type of pneumonia, such as the codes from category J13, pneumonia due to streptococcus pneumonia, and subsequently develops ventilator-associated pneumonia. In this instance, the principal diagnosis would be the appropriate code from category J12 through J18 for the pneumonia that was diagnosed at the time of the admission. We would also code J95.851 ventilator-associated pneumonia as an additional diagnosis when the provider has also documented that they have the presence of ventilator-associated pneumonia. New for 2021, we have the vaping-related disorder code. So for patients presenting with conditions related to vaping, we would use code U07.0 vaping-related disorder as the principal diagnosis. For lung injuries due to vaping, we would still assign only U07.0, assign additional codes for those manifestations, such as if they have acute respiratory failure or pneumonitis. Associated respiratory signs and symptoms due to vaping, such as cough, shortness of breath, etc., are not coded separately when a definitive diagnosis has been established. However, it would be appropriate to code separately if any gastrointestinal symptoms, which is not respiratory, such as diarrhea or abdominal pain occur. Now, there are no chapter-specific guidelines for Chapter 11, so we'll pick up next time with Chapter 12, diseases of the skin and subcutaneous tissue. So that's it for today. Next week, we're going to go over the skin and the musculoskeletal system. I hope you found this video helpful. If you did, make sure you give it a big thumbs up. Don't forget to subscribe and hit that notification bell so you will get alerts when I post new episodes. I will see you in the next episode, and until then, just keep on coding on.